Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features expert answers to clinician questions on the use of BTK inhibitors and other treatments for patients with chronic lymphocytic leukemia, or CLL. This episode is the second of 3 podcasts of CLL frequently asked questions in this series, and is part of a larger educational program titled Chronic Lymphocytic Leukemia: New Horizons with BTK Inhibitors. During this podcast, Dr. Jeff Sharman of U.S. Oncology Research in Eugene, Oregon, Dr. Danielle Brander of Duke University in Durham, North Carolina, and Dr. Nicole Lamanna of the Memorial Sloan Kettering Cancer Center in New York, answer audience questions from a live CCO webinar on topics including rechallenging patients with venetoclax and BTK inhibitors, the risk of secondary malignancies with BTK inhibitors, and the mechanism by which BTK inhibitors may reduce infusion reactions in patients with CLL. For more information on our faculty for this program, along with a link to the complete program, including downloadable slide sets from the webinars, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on these topics.
Nicole, I'm going to direct the first question to you, and this comes to us from Michael Roberts. And this sort of speaks to where the field is going and how you would manage a patient in the setting where they may have already received combination with venetoclax and ibrutinib in the frontline setting. So I know that that's a question for the field, and it's a challenging question, but I wanted to go ahead and direct that one to you since you had the relapse refractory topic.
Of course you did. All right, so that really is a challenging question. Clearly I think part of it is, similar to what we've been doing with the Ven-R Marano study and the Ven-I relapse study. So the question is, if somebody's already relapsed and had that combination, the question, will their disease be resensitive to venetoclax rechallenge? So depending upon maybe the time that they've been off obviously I would reevaluate their disease and look if things have changed. But one is maybe there possibly could be rechallenged with venetoclax to see if they're still sensitive. We certainly saw that with the Ven-R combination in relapse, that patients were, many of them were able to be rechallenged and went back into remission. One could even think about, adding an antibody to one of the novel agents in relapse. But it's important to know a little bit more about the disease characteristics, their time off of therapy. But certainly a Ven rechallenge would certainly be in the realm of possibility. And we don't know necessarily that you couldn't have a BTK rechallenge either. That wasn't done that way. So we don't know that somebody couldn't be rechallenged on one of the other, on a BTKI, for example, as well. So I think there's certainly less unknowns in this type of combination in frontline versus, somebody's had a BTK or had Ven as frontline and then hasn't had the other in relapse. So I do think that you can rechallenge. Certainly that would be something I would try to do, is rechallenge, but you might need additional therapy on top of that, maybe rechallenging with an antibody.
Super, thank you. And Dr. Brander, there was a question that came in during your talk that said, what is the mechanism that BTK reduces infusion reactions? And I think that was probably a specific to the Elevate treatment naive study where fewer infusion reactions were seen amongst the patients who received BTK obinutuzumab versus chlorambucil obinutuzumab. Is that one that we could hand off to you?
Sure. You led the study, but
I'm trying to moderate the questions here.
No, I'm just kidding. It's an excellent question. I think to highlight, I mentioned some other studies that looked at it, not just with novel agents, but actually some chemotherapy combinations. So patients got ibrutinib. There's the IFCR study, the FCO study. So it's not just ahead of that with obinutuzumab. But I think, as you mentioned too, BTK inhibitors have been studied in terms of inflammation and autoimmune disease. So I know there have been some correlatives looking at it. I don't fully know in all of those and the individual patients what the exact mechanism is, but this is certainly something that that BTK inhibitors have shown across several different studies. And I think the practical part of that is if they are going to be used in combination, to know that. So that might change how you sequence therapy. And the other last interesting thing is in some of these studies, they started ibrutinib the same day as the anti-CD20, but other studies they didn't. And as you and Dr. Lamanna pointed out, often when you start the BTK inhibitors, they give a lymphocytosis, so you might expect they might have more infusion reactions, and that is not what is seen. So I'll give the super smart answer saying something with the inflammation, but certainly has held true. And if they're going to be used moving forward, just to keep that in mind. And I think it's helpful in managing patients.
Yeah, no, I completely agree with you. And I think it's been demonstrated across a large number of studies and is consistent, and the mechanisms aren't completely worked out, but you can certainly see changes in cytokine profiles very quickly after starting BTK inhibitors. I've always assumed it was something related to that, but I don't think it's ever been specifically identified. So there was another question about BTK inhibitor as a second cancer engine. And I think that this probably refers also to the Elevate study. And it's been seen in some other studies. When you compare a therapy, I think the answer is that I believe this to be an artifact of how the study was designed rather than a true biologic feature. So in the studies that compare fixed duration therapy, whether that's bendamustine rituximab versus ibrutinib, or FCR versus ibrutinib, or chlorambucil obinutuzumab versus acalabrutinib, and so forth, the length of observation for adverse event reporting is generally the last dose plus 30 days. And if you're comparing a fixed duration therapy, which might be 6 months, versus a therapy that is indefinite, that might be, 2, 3, 4 years of median observation, there are necessarily going to be a higher number of cancers seen amongst those patients who are on continuous therapy, simply because their duration of observation is longer. If anything, in CLL management, is there that may increase the risk of second cancer? I tend to put that more on fludarabine rather than the novel agents. It is true to say that we don't totally know this 100%, but I think that that's the most likely. Dr. Brander, there was another question that came in that was maybe more a point of clarification, but there was a question about whether patients with 17p experience the same adverse events with ibrutinib than patients lacking 17p. And I was wondering if you could just sort of comment on how FISH testing, how we think about FISH testing vis-a-vis how our patients are going to do.
I'm not aware by prognostic markers, so FISH testing done either at diagnosis or relapse, probes for the missing or duplication of chromosome. Usually it's a common panel, and that'll report out on the percent. So I'm not aware by FISH testing of any differences in adverse events across the board, on trial or off. It would be hard to compare because off of trial patients tend to have higher of all adverse events. And lastly, I'll say, while the novel agents are very promising to use over chemoimmunotherapy, these are still the patients, even in the front line, at highest risk to progress on the novel agents. So hence highlighting the need for ongoing clinical trials and combinations for these high-risk patients that can still progress.
Thank you very much, Dr. Sharman, Dr. Brander, and Dr. Lamanna, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Chronic Lymphocytic Leukemia, New Horizons with BTK Inhibitors, and to download the slide sets associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.